All right. Sorry, I'm a little late here. I'm going to be missing part of this echo. I hate to say that, Cam, but I have a meeting I have to be at. So today we're going to have Cam Weaver's talked before, and he's got a really nice presentation set up for us. So next slide.
And as we have reiterated several times, our Echo platform will be changing as of December 6th. So if you haven't registered for your new Echo account, please do so. You can use the QR code, or Katie will share the link towards the end of the session.
And we have tons of talks coming up. I think Cam is going to be at all of these. I'm almost sure of it because he just loves this stuff. Next week, probably I'm going to be doing a talk on benzodiazepines and alcohol in pregnancy. It's a talk I already have done, and I'm thinking about doing it if we had somebody cancel. So I may throw that one in, but lots of good stuff, some on the correctional settings, things that you love. So just keep looking ahead.
And then Thursday, tomorrow, is the Joint Perinatal Improvement Summit held by Hennepin Healthcare and the partners listed at the bottom of the screen. So I think registration is still open for that. So if you're needing something to do to occupy some time tomorrow, please register. It's going to be really good. There's some awesome speakers.
Yeah, I think one of the things nobody knows is Hennepin said they would give free shrimp to everybody, as much as you can eat while you're there. I could be wrong, Cam. That was just a rumor I heard. So
yeah, it was leftovers, so I'm not sure on the date, but it's free.
Yeah, just free. It's a huge thing.
Yeah,
and
probably not true.
Smell it first. Just smell it first. That's what I would recommend.
Kurt's going to turn into a shrimp if he eats any more of them.
Remember, there's free CME, so please fill out the things Katie sends you. Cam loves to see your face, so please turn on your video. And he's a good-looking guy, so you want him to see you. So please turn on the video if you can.
If you have any technical assistance needs, our contact information is listed. Feel free to give us a shout if you need any help or advice with any cases.
Yeah, no personal problems. Can't fix those. And remember, all of this stuff is on the Opioid Resources Education site that Stratus Health keeps up. And so everything that we have is on there, old talks, you can watch them at your leisure.
Leisure?
Like leisure suit. Mm-hmm. Okay, so it's all back to Cam. So Cam, if you could do us a favor, maybe just introduce yourself. Some of the people may not have seen you speak here before, but Cam, we've known for a long time and gives some great presentations.
Sure. Well, thanks, Kurt, for that intro. I haven't been called good-looking guy in quite a while, so that feels pretty good. I appreciate that. Might only get. I see you're not wearing your glasses.
No.
Yeah. Okay. Yep. That's part of the problem. Yep. But yeah. So I'm Cam. This is what I look like. Sorry. I'm a clinical psychologist here at Hennepin Healthcare, working in downtown Minneapolis. I wear a few different hats here. One of them is within a primary care clinic. So I do a lot of work with primary care docs and kind of working as a consultant to them and to helping them meet the mental health needs of their patients here in one of our integrated primary care clinics, kind of designed to treat the kind of super utilizers of the hospital system, those patients that are find themselves to the emergency department and then admitted quite frequently. We've kind of developed a primary care home for them, and I serve that pretty high acuity population of patients down here. I also work on our consultation liaison service, which is kind of nicknamed trauma psych here in the hospital. So providing bedside psychotherapy services to patients who have been admitted to the hospital, either for illness or injury, and just helping them cope kind of in those immediate moments after often a traumatic event. I also am a part of our Echo series on opioid and addiction with Dr. Brian Grant. So I'm the consulting psychologist in that. And I also am one of the training faculty in our psychiatry residency program, training psychiatry residents in how to do cognitive behavioral therapy. So lots of different hats. I run around the hospital a lot, which is good for my brain. It gets bored really easily. So it's good for me to bounce around. Today, I'm going to be talking a little bit about trauma, and trauma itself is, let me share my screen here. There we go. Let's see. Trauma itself is a very large topic, and one for which you can devote an entire echo to. In fact, there are echoes devoted to it. So feel free to peruse and search the Echoverse for those. So it was really difficult to try to narrow down what exactly I wanted to talk about today. It's also really distracting to see my face, so I'm gonna hide the back. Okay, there we go. So what I'm going to talk about today is mostly going to be focused on what to do when, kind of, what is trauma? What does trauma look like? How might you spot it in those kind of immediate moments following trauma? So this might be something for which, you have a patient who's come in, they've actually very recently been through something or are currently going through something. Not all trauma occurs in isolation. So a lot of it can be repeated or prolonged. And so what does that look like? How do we address it both in that moment and then in the days and weeks to come, and what that might look like for folks, and just kind of what are some things that you can do in those moments to help out. So I apologize if you were looking for like a bigger review on post-traumatic stress or acute stress disorder. Those are other talks. I'd be happy to come back and give them. But this one's going to be kind of focused just more generally on trauma and what it might look like and what we can do about it when we see it. Okay. All right. Okay, so I think I just went through most of these. So hopefully, from this talk, you'll have just kind of a better sense of what these things are. Okay, so what is trauma? There's lots of different definitions of trauma, and we all kind of have our own definitions of trauma. I think it's important to kind of settle in on one, though, not just for the purposes of this talk, but also just in general as you navigate the work that you might be doing. So the DSM, which is the definition that I use, has what we call criterion A, which is an exposure to an actual or threatened death, serious injury, sexual violence, one or more of the following things. So the way that I kind of break this down is a trauma is defined as something that threatens life, limb, or integrity as a person. It can be, and historically has been, through direct experience, but it doesn't have to be. It could be something that you've witnessed. It could be something that you learned about happening, but that's kind of been more specifically defined as learning that something bad has happened to a close friend or family member. And that, even more specific, has to be something that happened that was accidental or violent. And it can be something that doesn't even happen to you, isn't related to you, but could be through the course of kind of repeated exposures to other people's trauma. So this could be a EMS worker. This could be a social worker who works in domestic violence. This could be a clinical psychologist who spends a lot of his or their day being exposed to trauma narratives from patients. So there are ways of kind of meeting this criteria, even if you haven't directly experienced trauma. SAMHSA has I think, a little bit less specific way of describing trauma, but the general themes are the same, right? So we're really talking about something that threatens life, limb, or integrity as a person. I think it's an important distinction to make, because not everything stressful that we go through is trauma, okay? And I think that's important because as we move into this era of trauma-informed care, which I'm 100% for trauma-informed care, we run the risk of maybe kind of diluting that term a little bit. And start kind of seeing anything that happens to anyone that's stressful as a traumatic event. And so my advice is often to kind of pump the brakes on that so that we really have a good idea of what we're talking about. It makes it easier to measure. It makes it easier for us to direct a response that's actually appropriate for the situation. It doesn't mean that other stressful things that happen to people aren't important and worthwhile and don't cause psychological or even physical symptoms because of them. We have other diagnoses that are within the realm of trauma and stress or related disorders within the DSM that can fit that bill, most specifically adjustment disorders. Okay, so I think that's important to just kind of get us off on the right foot and kind of have an idea of what we mean when we talk about trauma. Okay, so just so you have an idea of how common trauma is based on those definitions pretty common. Most people, almost all people, will experience at least one traumatic event at some point in their lifetime. Okay, so it's very common part of the human experience to be witness to or be affected directly by a traumatic event. Okay, most people who experience a traumatic event will have some symptoms, and I'll talk a little bit more here in a little bit about what those symptoms might be. So it's really common to experience trauma. It's really common to experience symptoms after trauma. In fact, this is an important point to make with patients following a traumatic event, that, yep, you're having symptoms, and what you're having isn't pathological. It's not something that we're going to diagnose today. It is a normal reaction to an abnormal situation. Okay, and that can be a nice little nugget that kind of helps ground people, and we'll get into more of that too in a little bit. So most people will experience symptoms. Only about 19% of people who experience a traumatic event go on to develop acute stress disorder, which, if you want to think of it, it's like a brief form of post-traumatic stress disorder. The symptoms are pretty much the same. The criteria of how you make the diagnosis is a little bit different, and I'll give you more information on this just so you have it here towards kind of midway through the talk. But essentially, it is PTSD symptoms with onset in the days following the trauma, but symptoms don't last beyond 30 days. Okay, beyond 30 days, then we're talking about post-traumatic stress disorder. But within that 30-day window, we would diagnose acute stress disorder. And only about 19% of all the people who experience trauma actually develop this kind of really acute phase stress reaction. Okay, even fewer develop PTSD. Okay, so what does this tell us? What this tells us is that the most common response to a traumatic event is recovery. Okay, most of us who are going to experience a traumatic event in our lives are going to have symptoms initially. And for most of us, those symptoms are going to go away. All right. And so it's really important when we experience trauma for ourselves, or when we are assessing trauma or considering whether or not there's some kind of diagnosis that needs to be made around trauma, that we're not just assuming that trauma is that some kind of trauma disorder is relevant to this particular person, because most people recover. All right. This is what I tell people in the hospital all the time. I'm bedside, they're having lots of symptoms, and I tell them, hey, if I was a betting man, which I'm not, but if I was, and I was going to bet on something really gross, I would put all my money on you recovering from this. Because that's the most common response for people. And so it's really important to kind of remember that. And it's really important, and this is something I don't just share with patients, I share this quite a bit with providers too, because I think it's something that we lose sight of when we're in that moment. Because in that moment, we're hearing something really horrible, we're acknowledging that something really horrible happened to this patient that we're working with, and it's not just their reactions that we're dealing with, it's our own reactions that we're dealing with too. Okay, and so we have to be kind of mindful of that. Okay, so what is that immediate response? So most of this audience, I hope, if not all, has heard of the autonomic nervous system and the sympathetic branch and the parasympathetic branch of the autonomic nervous system. And the most immediate response to a traumatic event is kind of twofold. One, it's that sympathetic arousal, that fight or flight response. And it's those kind of symptoms that you all might think of when you think of the fight or flight response, which is, again, a normal response that the body has, that we've evolved to have in order to keep ourselves safe. Okay, so this is how our brain responds and how our body responds in order to meet the demands of a perceived threat. Okay, so increased heart rate, increased respiration, thermal regulation through sweating, that increased, kind of hyperventilation, increased oxygenated blood to the muscles, can lead to dizziness and lightheadedness, especially if we're not in the middle of fighting and running, but we're actually kind of sitting still or freezing. We're not using that oxygen in the muscles, and that kind of gives us kind of a more of a lightheaded, dizzy feeling shaky in those moments. And of course, the HPA axis is activated in that time too, which, among other things, releases adrenaline and cortisol. And cortisol release has been shown to enhance the use of glucose in the brain in that immediate moment. So early on, cortisol release is really helpful kind of in the middle of a fight or flight response or in the middle of a trauma reaction. It decreases digestion, so sometimes you'll get upset stomach and those sorts of things. But in that moment, it's basically helping to redirect the body's energy to keep you safe, either by running, freezing, or fleeing, or fighting if necessary. Okay. In time, it's that same kind of disruption of that kind of negative feedback loop of the HPA axis that can cause some kind of more downstream effects that we'll talk about in a second here. Okay, so what might it look like? Kind of that's like that initial kind of fight or flight response. Again, it's completely normal, right? Just to go back to it real quick for a second. One of the things that when I'm talking with patients about this that I do is, and I'm going to have to look at my face again on the screen. I'm going to have to open it back up, unfortunately, because I need to be able to see what you can see. Okay. So what I'll say to patients in these moments is that this is our brain. Okay. All right. We got this wrinkly cortical structure, outer part. All right. I tell them that in this model, this part of the brain here is right here. Okay. And this is the part of our brain that does all the planning. It is the executive functioning center of the brain. It helps us plan. It helps us pump the brakes on things we may or may not want to say. It helps us organize. And of course, other kind of wrinkly cortical structures of the brain matter too. But our brain is not just that wrinkly part you see in pictures. There's things beneath that. There's subcortical structures of the brain that are also important. And my thumb represents this kind of area of the brain that we call the midbrain, all right? And within that midbrain is something called the limbic system, all right? And a part of that limbic system houses memory, and part of that limbic system houses the part of our brain that responds to threat, okay, and processes those kind of emotions, right? And so when we are triggered, right, when something threatens us or we perceive something to threaten us, all right, that part of our brain that does the thinking, that does the kind of the rationalization, that helps us plan and tells us what to do, kind of goes offline. And the part of our brain that takes over is something more fundamental, something more animalistic even. And so what I'll often describe is that our brains are kind of like a rider on a horse. And when things are calm and things are going okay, this is how our brain functions. The rider tells the horse how fast to go, how slow to go, to turn left, to turn right, to back up, and it works just fine most of the time. But every once in a while, a horse gets spooked on the trail, something happens, and in that moment, the rider gets bucked from the horse, right? And the horse does what the horse does to stay safe, what all animals do to stay safe. It runs, it bucks, it gets to a point of safety, and it's not until it gets to that kind of initial point of safety that it's going to eventually start to calm down. Breathing is going to slow. It might discharge adrenaline through shaking or, stomping with its hooves. And it's not until that moment when safety is kind of assumed again by that animal that the rider can get back on the horse and make decisions. And so when you see somebody in those immediate moments after a traumatic event, the rider is often off the horse. Okay. And so in those moments, our strategies are going to be different. Okay. We're not going to necessarily be giving a ton of education, maybe beyond what I'm saying right now. We're not going to try to rationalize. We're certainly not going to encourage people to make big decisions about their future in those moments, right? Because I guarantee those decisions they're going to make about their future are going to be in the direction of fight or in the direction of flight. And that might not ultimately be helpful for them. Okay. So rider and the horse, it's a really good metaphor. Patients really seem to get it. It can be helpful. All right. So what are some of those reactions that kind of happen, later, days, weeks following a traumatic event? The common kind of psychological reactions, losing hope for the future or a sense of foreshortened future. So one of the things that happens when people experience trauma is their brain has to make sense of that. Our brain doesn't like missing puzzle pieces. And when something new happens, our brain has to figure out what the heck to do with it. And so one thing that the brain might do is it might take that particular event and overgeneralize it to other events. So everything is going to go bad. I'm going to die, some kind of horrific and death, and it's not going to be too far out in the future. Nothing good's going to happen to me anymore. The brain might take a different approach. The brain might try to understand what just happened through self-blame. So if the brain has this belief that I'm in control of my life and I make good decisions and generally good things happen to me, and this accident happens, it disrupts that idea that you were in control for a minute. One way to maintain a sense of self is to say, no, you were in control. So what did you do wrong to make this happen? That leads to shame, that leads to guilt, self-blame. And so those two reactions are not uncommon following a traumatic event. Now, what happens, again, this is without any help from me or any other psychologist who studies trauma. For most people, those ideas that the brain kind of plays around with as it tries to figure this stuff out start to soften over time. And what usually happens is you meet somewhere in the middle, right? You are in control in most aspects of your life. You are autonomous. You are independent. You do make good decisions. The world is safe generally, but sometimes things happen. And there was that thing that happened to you, and that was horrible. And it'll never be a good memory, and it might even bring up uncomfortable emotions, but that's kind of as far as it goes. It doesn't go on to develop something that causes significant impairment in functioning or significant daily distress in their lives. Okay, so that's kind of usually what happens, right? For some people, it doesn't. And when that doesn't happen and those kind of beliefs become more solidified, usually through patterns of avoidance, which we'll talk about in a little bit, then we start thinking a little bit about acute stress disorder in that first 30 days and maybe even post-traumatic stress disorder later. Okay. Again, if that negative feedback loop of the HPA axis is disrupted and cortisol levels stay high for an extended period of time, which is not uncommon for people who are exposed to prolonged or repeated traumas, you'll see things like sleep difficulty. You'll see things like increased pain response, long-term heart disease, long-term digestive problems, weight gain, memory impairment, all the things that have been kind of associated with cortisol specifically. But some of these, might not just be cortisol. I can't say that there isn't some cortisol's not playing a role, but at the same time, if you're in a situation where trauma is repeated or prolonged such that you're not actually safe, some of these things that obviously on this slide look pretty uncomfortable might actually be very adaptive in the moment. And so another thing to consider with a patient is what's going on in their life, what's really happening here, and are these symptoms actually keeping a person safe? Okay, quick example. If you are a combat soldier, if you're U.S. Army and you're in Fallujah around 04, 05, there's probably a pretty good chance that a lot of people you saw around you did not trust. There's probably a pretty good chance that you were very vigilant, always on guard, always checking your six, maybe a little jumpy even. Some of those things maybe were trained in you since basic training. In those moments, those symptoms, which we might see in like at the grocery store and think, oh, this is PTSD. In that moment, those symptoms are actually facilitating safety. So if you have patients who are in dangerous situations, some of these symptoms of trauma are actually symptoms we wouldn't want to treat because we want the person to stay safe in that moment. All right. It's adaptive in that situation. Now, once trauma is removed and the person is in a sense of relative safety and those symptoms persist, now they become maladaptive, right? And then we want to treat. So just, again, something to think about. Okay, so I mentioned acute stress disorder and post-traumatic stress disorder and what do those things look like. Really, the symptoms are pretty much the same. With acute stress disorder, you just have to have 9 or more of any of the symptoms from any category. It doesn't matter. So symptoms of intrusion are intense memories of the event, nightmares, psychological or physiological reactivity to trauma-related cues, obviously negative mood, even dissociative symptoms like an altered sense of reality. Some people report time just feels like it stands still. They feel like they're floating through their life. They feel like they're kind of outside their body looking in. They might not remember parts of the traumatic event. Sometimes those memories do kind of come back and to kind of down the road, someone's like, oh yeah, that happened. I forgot all about that. Holy cow. How come I haven't thought about that before? How did I not remember that? Or sometimes those parts of the event never come back, right? And I think it's also important to note that a flashback and like an intense memory are two different things. Patients will talk about flashbacks a lot. But flashbacks are actually kind of a really scary dissociative state where somebody in that moment truly believes they're back in that situation, All right. They smell the smells, they hear the sounds, they see the sights, they are really out of it and think that they're back in that traumatic event. So there's a dissociative component to it. An intrusive memory is just that. It's a memory. It can be very detailed, it can be extremely intense, but not a flashback. So those two things are different. Avoidance symptoms. And avoidance symptoms are really important, not just for the development of post-traumatic stress disorder or acute stress disorder, but they also turn out to be quite important in the maintenance of the disorder. So we often see people trying actively to avoid memories, thoughts, feelings, try to avoid cues. So these folks isolate, they don't go out very often. They might use substances to try to avoid feeling or thinking about things that have happened. When they do think about it, they just kind of shudder and kind of move on without actually trying to process it. And then there's symptoms of arousal. And so these are things like sleep difficulty, irritability, poor concentration, hypervigilance, that kind of always looking over your shoulder kind of feeling. I always say that I can tell the patients that come into our clinic who have experienced trauma based on where they sit in the waiting room. Because oftentimes they're going to sit with their back against the door or back against the wall facing the door. Back against the wall facing the door. That way they can see everyone coming and going and nobody can sneak up on them. Okay. So those are kind of the symptoms of acute stress disorder. Again, these symptoms have to be present in the days, weeks following a traumatic event and don't last more than 30 days. All right. Post-traumatic stress disorder, the symptom criteria are very much the same, but you have to have symptoms from each kind of cluster of symptoms. It has to last more than a month, but it's generally, I won't go through it here. It's generally the same symptoms. Okay. You just have to have 2 or more of the alterations in mood or thought, 2 or more of the hyperarousal symptoms, 1 or more of intrusion, and again, the avoidance. Okay. So what do you do kind of in those acute moments following a traumatic event? Someone comes into your office, maybe it just happened. Maybe it's something they're kind of actively going through in their lives that isn't maybe over yet even. I think it's really important that we kind of check our knowledge of like pop psychology at the door a little bit. Okay. So it's really common for people. I hear this in the hospital all the time, usually from family members, not from providers, but I hear this a lot in the hospital when I'm working with patients. I'll be working bedside with someone who's just been shot or someone who's just been in a really bad car accident or poured gasoline on a bonfire. Don't do that, by the way. See it a lot here. And there's family member in there and they're like, this is hours, maybe days after, at the most, after a traumatic event, and the person is meeting with me and we're talking and the family member's sitting there and they say, you know what, they just won't talk about it. They need to talk about it. Can you get them to talk about it? They're not going to get better if they don't talk about it. That is actually not true. Okay. So forcing somebody to talk about it could actually traumatize them more. All right. So there was this old intervention called psychological debriefing that was done and thought to be really effective initially. It was used a lot like following natural disasters. The psychologists would get like deployed after Hurricane Katrina, for example. Psychologists got deployed to areas where displaced people were, and they tried to provide these kind of interventions where they basically got people in groups and forced them to process and talk about what they're happening. What some of the research has actually found is that by forcing people to talk about it in those moments following a traumatic event, not only is it not helpful, it actually can make the symptoms worse long term. Okay, so forcing someone to talk, not great. Okay, but if somebody wants to talk, absolutely allow them to. Okay. So when trauma happens, it happens in the context of a lack of safety, a lack of trust, and a lack of control. Okay. And those 3 things get disrupted. One of the things that we can do that's really helpful in those moments is to help reestablish that. If they're in your office, we all know it's probably a safe space. Okay. They might not see it as a safe space. In some patients, trauma occurs in a medical setting. So take that with as you will, but helping establish that this is a safe space for them. Okay. Helping them establish trust with you. All right. And some of that comes with you listening to them, you believing them, you describing what you're doing, why you're doing it, those sorts of things. And then of course, putting the control as much as you can back in the patient's hands. Okay. And so trying to reestablish those three things. And so if you're forcing them to talk about it and they don't want to talk about it, you're not reestablishing control for the patient. If you are, if they want to talk about it and you're not letting them talk about it, same. Okay. All right. It's okay, even in those moments, to ask a patient what they feel like they need in that moment. If they talk about needs that are long-term, right? They say, oh, well, I need to move. I need to change jobs. I need to fly away somewhere, or I need to attack the person that attacked me, or anything like that. Remember, rider's off the horse. This is maybe not the best time for them to make those kinds of decisions. And so I'll often say something like, I hear you. That might not be something we have to decide today. What is it that you feel like you need right now? And I might give them the rider and the horse metaphor as my rationale for why I don't want them to make those kind of long-term decisions in that moment. Ask permission before giving advice or doing any kind of procedure or anything that you might need done for the visit. Okay. Assist the patient in establishing voluntary control of an involuntary process. What does that mean? Deep breathing. There's only one aspect of the fight or flight response that we actually have voluntary control over, and that is through our breath. Okay. And so helping people develop a deep breathing exercise can be really helpful. And the way I describe it is, I want you to breathe like you're sleeping. All right. And when we sleep, our chest doesn't go up and down. Our stomach goes up and down. And so what we're going to try to do is imagine that our stomach is a balloon, and we're going to take a nice inhale, and we're going to inflate that balloon in our stomach. We're going to hold for 1 second, and then we're going to take a nice long exhale. It's on the exhale that we establish, I don't go into all this necessarily, but it's on the exhale that we establish vagal tone, right? Our heart rate variability improves on the exhale. It's on the exhale that we're actually relaxing. We have a more variable heart rate. That's that signal to our brain that we're from our heart through our breath that we're safe. Okay. And so telling them that, saying we're going to do a breathing exercise. This is the part of this response you're having that we can actually control. And just talk about extending that exhale, not to the point that it's uncomfortable, but just extending that exhale longer than you might otherwise do if you weren't trying to be purposeful about it. Okay. So if you need a number, 3 to 4 seconds in, 4 to 6 seconds out, I don't get too caught up on, especially in these moments, in a really acute phase, on, is it are you going in through your nose and out through your mouth or whatever? This can be challenging for people in the hospital. We have patients with COPD for which deep breathing is difficult. You might have patients who are their breathing is being assisted with oxygen and other things that might make it kind of difficult for them to do some of these exercises. So kind of take those things into consideration. Utilize grounding techniques in those moments. Okay. So what you're trying to do is you're trying to reorient the patient away from what just happened or what's happened in the past, which is traumatic, and reorient them to the present. So again, we're reestablishing safety, right? And so what I'll often do is I'll say, you're safe now. And as you're breathing, as you breathe out, I want you to say now. Okay. Or I might say, I want you to tell yourself you're safe now. And I emphasize the word now, because you're safe means what when you don't feel safe, right? But if you emphasize now, then what you're doing is you're getting the word safe in there, you're kind of sneaking it in there, but at the same time, you're reorienting the person's attention to now, okay? There's other techniques you can do. Foot tapping works really well. Having the person like touch the hem of their pants and kind of describe that sensation can be helpful. I really like to have patients name objects in the room. Okay, so I'm looking around my office and I can say water stained ceiling tile, brick, calendar, psychology textbook, other psychology texts. There's a lot of psychology textbooks in here. I'll stop. And just start naming the stuff in the room. And where that can be helpful is, again, you're just kind of reorienting them to the present moment. It's really difficult to think about the past when you're verbalizing out loud the present. Okay. And so that can kind of help bring them back to that center. All right. Again, assist patients to understand what's happening in their body. This is that rider and the horse example I was telling you about a little bit ago. Just kind of giving them an idea of what they might be experiencing. Okay. And then validate and normalize the reaction. Again, this is acute phase of a trauma reaction. This is a normal reaction to an abnormal situation at this point in the game. Okay. And so validate how they're feeling, normalize that reaction. This might be an opportunity then to talk about, what to expect, the most common response to trauma is recovery, that sort of thing. Okay. So in general, when you're working with patients who have experienced a traumatic event, it's important first, I think, to consider their behaviors in the context of like a larger ecosystem, that trauma for them doesn't happen in a vacuum. It happened in the context of their lives. And this is kind of where trauma-informed care comes in. This is like another way of saying trauma-informed care. Essentially what you're saying when you provide trauma-informed care is that you're sensitive to and acknowledge the lived experience of other people having been potentially traumatic and maybe stressful, and that the behaviors that you see in clinic may be reflective of that lived experience and not of anything personal or of anything intentionally directed towards you as a provider. Okay. So this kind of explains the behavior. It doesn't necessarily excuse it, right? So it's not as though you have to allow yourself to be in an unsafe situation. You can't provide good medical care if you're not feeling safe, right? So what it does is it just helps us be a little bit more compassionate, a little bit more understanding. Oftentimes what I'll say to providers is when they see kind of a behavior, maybe it's, it's kind of loud, maybe it's really assertive, maybe it feels aggressive, maybe they use lots of hand gestures. I'll remind providers that these behaviors did not just develop in the waiting room, that these behaviors developed over a long period of time, and behaviors only continue to occur if they're reinforced in some way. So in some area of this person's life, those behaviors are effective, even if they're not effective here in the doctor's office. Those behaviors have been effective for them at other points in their life. All right. And so just acknowledging that, again, it doesn't excuse the behavior, but it kind of helps us better understand it and maybe provides us with a little bit of compassion for what they might be going through. And we might be able to use that as data to figure out how to help them better. Remember, safety, trust, and control. Okay. So supportive posture, not sitting with your arms crossed, trying to be as open as possible, feet on the floor, hands in the lap, hands on the knees, whatever, just relax. Okay. Trying to use a calm voice. Try not to speak with a lot of gestures and hand motions. This is something that I fail at all the time. I'm pretty animated speaker, so it happens for me a lot. I have to be very mindful of it. Try to avoid like the sudden movements, loud noises. Before performing any procedure or touching the patient, ask and provide a rationale as to why. Okay, because again, they're trying to reestablish a sense of safety and trust. So knowing why you're doing something in the context of having some control over whether or not you actually get to do it is important. Sometimes there might be things as physicians and advanced practice providers that you have with your patients that you might not necessarily be able to not do. Okay, it might be something that's really important to the visit. It could be a safety issue, what have you. In those moments, if at all possible, try to at least give the illusion of choice. Okay, like if you know that getting their blood pressure is super important, but that requires kind of touching them, or say, hey, how about this? Or say, do you mind? Do you want me to get your blood pressure before or after I have you fill out this form? If you're gonna, get right up in their face because you're looking into their eyes, and you also know that you have to get a blood pressure. Hey, would you like me to look in your eyes now or after I get your blood pressure or whatever? Okay, so just kind of give this illusion that there is some choice to it. And that's actually a good parenting tip too. On the side note, right? Do you want to brush your teeth now or after you get your pajamas on? Right, both things are happening. You get some say in the how. Right. And so those things work with patients too, is just to kind of help give that illusion of choice. It's okay in those moments to acknowledge that a lived experience of a patient is different from your own. Right. And you don't have to acknowledge it necessarily to them, but acknowledge it to yourself. Okay. Again, normalize, validate. It's okay to discuss diagnoses and treatments. Right. I recommend people do so in terms of evidence-based practice. One, again, if you want someone to feel like they're safe and they have trust, especially if trauma occurred in the context of a medical setting, it's really great to reiterate to the patient that what you're giving them is the state of the art. All right. You're not giving them something less than because of some demographic variable or some, kind of historical thing that is a part of, especially our patients of color who have lived it and have learned it, and is often passed down generationally, but that they are getting, in fact, evidence-based practice. They're getting the state of the art of care. As you discuss, those things can be really helpful. And this is really important when the answer is no. Okay, so a lot of times patients come in and they think that they're going to tell you what it is and that you're going to give them something, right? Sometimes the best medical opinion that you can give based on the best available evidence and patient characteristics, which is evidence-based practice, is to say no, all right? And I'll often kind of phrase that no in terms of the best evidence. I don't have to do it as much in my job as people who prescribe. So I get to be the good object. You guys get to be the bad object. I get to come in and be like, oh yeah, I can't believe it. No, I would never do that, but you get my point. Okay. Be consistent. Again, trust isn't built overnight, right? So being consistent is really helpful. Take your time. Take your time to build it. The most important thing you can do for someone who is in a scary or dangerous situation is get them to come back, right? And if you go too fast and too hard, you might push them away, right? And so getting them to come back, taking your time is important. And it's not just taking your time, it's taking their time, right? Let them take their time to establish that sense of trust and safety too. And don't assume trauma, assess for it, okay? So we make a lot of assumptions when people have experienced a traumatic event of how they're going to react and what diagnosis they're going to have. But they might not. They might tell you about this really horrible thing that happened, and they might be doing great. They don't need a referral to me necessarily, all right? So I always recommend trying to assess. If you have access to someone like me to do that assessment, that's fine. If not, there's brief screens. This is the one that the PCL5 is what we have in our kind of embedded into Epic. So you can have them fill out the PCL5, and you can use kind of at-risk scores. You can kind of get into a little bit more detail with, kind of the specific symptoms that they might endorse as moderately or higher, or you can just kind of use that cutoff score of about 31 as a way of indicating, hey, this person is kind of being flagged for potentially having some significant trauma symptoms that are impacting their ability to function in their daily lives and maybe causing significant emotional distress. All right. Obviously, referring to mental health professionals if you can. And then the most effective forms of psychotherapy that I'm just going to mention here, again, this is a completely different talk. There's three. Cognitive processing therapy and prolonged exposure therapy have very large research backgrounds. EMDR also is listed as an empirically supported treatment. Everybody kind of has their opinions on eye movement desensitization and reprocessing therapy, all of which have to culminate in acknowledging that it is an empirically supported treatment, even if it's something as a professional you're not sure about. It's not something that I do. I think some of the studies and dismantling design studies of it have not shown that the eye movements or those exercises add any kind of active ingredient to a therapy. It doesn't outperform other exposure-based therapies, which is what EMDR is, an exposure-based therapy. But it is an empirically supported therapy, and patients really seem to dig it. And providers really dig it because there's lots of training on it. It's a cool approach. You do see results, just like you would with learning these other skills. But yeah, so those are just a few. Yeah, okay, that's all I got. All right.
Thank
Any
you
questions?
so much. That was awesome. And I loved the rider on the horse analogy. That was great. And it's such a practical way to be able to explain that to your patients.
Mm-hmm.
Also love the parenting advice. You can keep more of that.
I have a 14-year-old now, and one thing I know, the only thing I really know about it is that I am horrible at this. So like, don't take parenting advice from me.
I'll take all the help I can get. One question that I had is, do you have any canned phrases or suggestions for trauma patients and gender?
Say that one more time. Say that one more time.
Do you have any suggestions with like phrases and how to ask permission from a patient that's experienced trauma? Like my mind immediately goes to like patients who have been sexually exploited or rape victims.
Mm-hmm.
Like, Kirk was in the room and he's a male provider.
Mm-hmm.
How do you phrase that to the patient to establish safety? I've wondered that a lot.
Yeah. So again, so if this is like immediately following a traumatic event, my answer might be different if it's been a while. I think it's very appropriate, at least early on until trust is established, that you have somebody in the room with you at the time, if possible. Again, ask the patient what their preference is. You absolutely might be in a situation where there is not a provider of the gender that is preferred by the patient is available. All right. For me, for example, I am the only psychologist in my clinic. There is not a female option. And so people who are going to be seen, at least initially, until we can get them kind of more permanent care if necessary, are going to be seen by me. That's the way it is. And so if again, I would go back to asking permission. I would go back to explaining why you're doing something. I would, if it's possible to have some kind of medical staff in the room with you, whether it's the medical assistant or an RN, LPN, just somebody. If it's appropriate and they have someone with them that's family, that might be okay too. Kind of more long term, if it's somebody that I get a lot of that where it's like, oh, I don't know if I want to meet with Cam. He's a guy. I might say, well, it can be actually really therapeutic for you to establish safety and trust in somebody that otherwise maybe makes you feel uncomfortable because it reminds you of a traumatic event. That can actually be helpful, right? And then it's just a matter of kind of going slow. Letting them, a warm handoff is a great way to start. All right. So in their head, Cam might look like their assailant, and in person, I might not. Right. And so that can kind of demystify it by just doing a warm handoff and saying hello to start with, and talking to them about, hey, it can be good to try to reestablish a sense of trust and safety, and even therapeutic. And I think also when we think about how we treat PTSD, so PTSD is a unique diagnosis, and acute stress disorder, they're unique in the sense that something has to like really happen to you before you can be diagnosed with it. Other things, yeah, something might happen. And PTSD is not the only diagnosis that someone who experiences trauma can have. People who've experienced trauma might not develop PTSD, but do develop generalized anxiety or do develop major depressive disorder. So that happens too. So, but for PTSD, it's like one of those unique diagnoses where something definitely has to happen before you can be, develop the disorder. Okay. And so there's that piece of the etiology, but the other piece is avoidance. And so trauma is often PTSD is kind of built and maintained through avoidance, and treatment is all about approach in one way or another. Okay. And so that's something I share with patients too.
Cam, I think it's kind of interesting because, and I see a lot of patients who come in from pain clinics and they're on all these opioids, and their history is very complicated: PTSD, sexual assaults, all kinds of stuff. And I think I've more learned through experience that I don't change anything the first time I see anybody. I mean, I guess I'm wondering what you think of that approach. I just say, listen, we're not going to change anything at the end of this. We're just going to have the talk, because that group seems to be really difficult. Is that, would you say
that's awesome? Yeah. I mean, obviously if there's something going on that's super unsafe, whatever, but, I think in general, yeah, I mean, again, it kind of goes back to that low and slow approach, right? So to establish safety, trust, and control for a person who's been through a lot of trauma, you have to go slow. And saying that to them up front can kind of help let their guard down a little bit.
Yeah. It's interesting because their first perception is I'm there to cut them off, right? I'm there to change something big, and you don't ever want them to feel like, I'm the axe man. I'm coming in here to change things, and yeah, it is really how that group kind of responds to that.
Right. And I don't think I gave it to your group, but I gave a talk on like the connections between pain and PTSD. And if you think about, how pain is experienced in the brain, it's not just this kind of cortical structure in the somatosensory cortex that kind of travels down to your lower back or your knee or wherever your source of pain is. It is processed through the amygdala. It is processed through the hippocampus. Your brain in that split second is referencing memories, past experiences. It's referencing threat, and that's how pain is experienced. And so if you're operating your life under like kind of perceived threat at all times, it's going to exacerbate your pain experience. And so giving them, again, that sense of control, that they can trust you, that you're not just going to cut them off, right? That they can kind of feel safe, because that's what, I mean, the opiates are certainly treating, hopefully treating their pain, but patients are still experiencing pain, right? Most of our patients on opiates are still experiencing pain. So the opiate isn't actually making the pain go away. What it is probably doing, though, is treating something in the midbrain. It's probably doing a lot to treat kind of their perceptions of threat in the moment.
Any questions from anyone else?
Yeah.
I see Molly put in the chat, it's also important not to assume the gender of the patient. And you're absolutely right.
Oh, yeah. Yeah. And here, okay. So I don't do as much of this work now because of how my roles have shifted at the hospital, but for a while I worked in the gender and sexual health clinic, and I did a lot of evaluation. So, and this can be kind of a tricky subject for people. It's just important, like, yeah, I agree. Don't assume gender. At the same time, don't assume that you've like overly offended somebody by accidentally dead naming them or using the wrong pronoun. Just correct it, acknowledge it, and move on. Okay. If there's a larger conversation that needs to be had, the patient can address that. But I don't know how many times I've heard that from both from our staff and from patients, that like, just say sorry or just correct yourself and move on, and not make a huge thing out of it.
All right.
It's really awkward. It's really awkward. Just be like, oh my God, I'm so sorry. It's like, okay.
Anybody wants to unmute and ask any other questions? Hearing none. Well, Cam, as usual, I wish I could have heard the entire thing, but
You didn't miss anything.
Yeah, I did. Sounds like it was very. We really appreciate the time and expertise, and every time you come back, I think everybody learns a lot better way to kind of connect with patients and give them the care that they should get. So thank you so much.
You're welcome. Happy to help.
Christine Bell just put in the chat, any new information about epigenetics and trauma?
No. Sorry, not my area. Is there like anything specific that you're asking about?
You can unmute if you want, Christine. That'd be easier.
I know. I was just thinking about those people affected by the war, and I was just thinking about this whole new generation with the trauma.
Oh, yeah. So, I mean, more to come on kind of these current conflicts, right? But there is a lot of, you don't have to even go outside our country to see like how like trauma is kind of passed down through generations. Yeah, we see it in healthcare a lot, especially with our patients of color. Here in Minnesota, we have the largest population of Somali immigrants anywhere in America. And a lot of them here in Minneapolis, and so we treat a large number of those, and we see that across the board too. Many of them have witnessed the atrocities of war. Some of them have been child soldiers. A lot of sexual assault that I think that it kind of goes overlooked within that community, typically because of stigma around it. So yeah, I mean, I think that those things are important to assess for, and they don't come out right away. Often it might be something that kind of comes up as you again build trust with that particular patient. But it's okay to ask about their lived experience too.
All right. Well, perfect. Well, thanks again.
Thank you so much, Cam. That was great.
Yeah, you're welcome, guys. Good to see you.
Yeah, you too.
All right, everybody. Have a great week. We'll talk a little bit about benzos and alcohol and pregnancy next week.